Welcome, everyone. This is GU Oncology Now. Today, we will be conducting an interview with Dr. Ida Sonni. Dr. Sonni is a nuclear medicine physician trained in Italy at the University of Rome Sapienza. She's currently an academic researcher at UCLA, working at the Department of Radiology and focusing mostly on clinical research of prostate cancer. Today, we're going to be discussing PSMA-PET and specifically to understand how we can utilize PSMA-PET to inform therapeutic plans for patients with high risk of recurrence. So welcome. Myself, I'm Akhil Saji. I'm the Chief Urology Resident at New York Medical College, and I'll be conducting this interview.
Hi, Akhil. Nice to meet you. It's a pleasure to be here.
Pleasure to have you. So we'll jump right in. Our first question is, could you briefly explain to the audience what PSMA is, and then also just briefly review the biochemistry behind its application in prostate cancer?
Sure. So I'm sure that most of you know what PSMA stands for. The term itself, prostate-specific membrane antigen, already tells us what it is. PSMA is a membrane antigen or a transmembrane protein that is expressed on certain types of cell, on the cell membrane of certain types of cells. It is, differently from what the name implies, it's not specific for the prostate. It is also expressed on many other cells, many other tissues like the salivary glands, the small bowel, the liver, for instance. It's also expressed in the endovasculature of some solid tumors, so it's not specific for the prostate. But the reason why the term prostate specific really stood with us, and we're using it currently to call this protein, it's because it's highly overexpressed in prostate cancer cells. And this is something that is really important for us as nuclear medicine physicians when we want to develop a PET radiopharmaceutical. We want to have a target that is highly overexpressed in whatever we want to image. We want to have this high tumor to background contrast that allows these lesions that express the target to really stand out when we're looking at the PET images. So this high overexpression, we're talking about hundreds to 1,000 times higher expression in prostate cancer cells compared to the normal tissues, the normal prostate, the normal background. This overexpression allows us to have really good images and makes the PSMA-PET images relatively easy to interpret. And this is the reason behind the success of PSMA-PET. It is highly overexpressed in the majority of prostate cancers, and it is an ideal target for nuclear theranostics. So we can use it for PET imaging, and we can also use it for radioligand therapy. So we can label with different radioisotopes and do both imaging and therapy. So the whole concept of nuclear medicine theranostics.
Great, thank you. So now that we have a basic understanding of how PSMA works, could you review the commonly utilized radiotracers that are found that are utilized by being attached to PSMA-based compounds, and then perhaps explain the differences between the different ligands?
Sure. There are different radiopharmaceuticals that target the PSMA. Some are used for PET imaging, some are used for radioligand therapy, some are used for both. I will talk a little more about the two radiopharmaceuticals that are approved in the United States and the ones that we have more experience with as well internationally. Those are gallium-68 PSMA-11 and fluorine-18 DCF-PYL. So these are the only two that are currently approved by the FDA for use in prostate cancer. These two radiopharmaceuticals, they belong to a same family. They basically have a part of their chemical structure that is similar, that is identical. And this is the part that targets the PSMA. It's a urea motif, so it's specifically binding and attaching to the PSMA. So this is the part of both of these radiopharmaceuticals that gives them the specificity for PSMA. So in terms of specificity, they're absolutely identical, we can say. The specificity binding with the molecule, with the target on the prostate cancer cells is the same. So if you're asking me from a clinical point of view, what is the difference? I would say there's not much of a difference. They should be considered almost identical. So the studies that were used for the FDA approval for both PSMA-11 and DCF-PYL, in both the clinical indications of initial staging and biochemical recurrence of disease, they basically obtained almost identical results in terms of diagnostic accuracy. So we're talking about very similar sensitivity, specificity, positive and negative predictive value. So clinically, they're almost identical. But if you want to know a little more about the differences, I'll be a little more technical. I'll talk a little more about the radiopharmaceutical and the way they're composed. So the radiopharmaceuticals that we use in nuclear medicine, they have two components, the radioactive part and the pharmaceutical part. Pharmaceutical part, in this case, it's the part that targets the PSMA, that gives it the specificity to the molecule. And then we have the radioactive component, that is the radioisotope. In this case, both PSMA-11 and DCF-PYL, they're radiolabeled with the isotopes that emit positrons, so we can use them in PET imaging. So PSMA-11 is radiolabeled with gallium-68 that is produced in a generator. The generator allows us to do the synthesis of only a small number of doses of gallium in a day, which basically means that we can image a small number of patients in a day. Fluorine-18 is produced in a cyclotron. The cyclotron allows us to produce much larger quantities of fluoride, and we can image many more patients. Another important difference, physical difference of these two radioisotopes is that they have different half-lives. So the half-life tells us how long the radioactivity remains in this radioisotope. And basically, gallium-68 has a shorter half-life and fluorine-18 has a slightly longer half-life, which is an advantage because if you have a hospital that has a PET scanner but does not have a cyclotron, you can have the fluorine-18 being produced in a different facility and then delivered to the facility that needs to use it for imaging. With gallium-68 having a relatively shorter half-life, this is not possible. So we have some limitations with the gallium-labeled radiopharmaceuticals, and I believe that this is it's an important practical reason that makes the fluorinated versions of these radiopharmaceuticals more likely to be widespread in the future. So another maybe small difference can be from the remaining part of the chemical structure. They have slight differences, so the biodistribution can be slightly different, but from a clinical standpoint, which is what we care about, they are to be considered almost identical.
Okay, thank you so much. That's really interesting to hear, especially about the half-lives and how that can impact delivery of these compounds to different areas of the country. So for the next question, we know that in the past couple of years, PSMA-based imaging has been gaining mainstream traction, especially in the metastatic prostate cancer sphere. However, it appears that its utility, whether in a diagnostic capacity or in a theranostic capacity, and the clinically localized or locally advanced patient population is less clear. Could you explain how what the current thinking is behind utilizing this technology and in these patient groups, and how that can inform treatment planning?
Yeah, so I can talk about my experience working with directly with the radiation oncologists. They are the physicians that are in charge of treating the oligometastatic disease or the clinically localized or even the locally advanced disease. So I know that there's a high reliance from the radiation oncology community on PSMA-PET. And I believe that the use of PSMA-PET has significantly changed the way they are treating their patients. So if you think about it, in the pre-PSMA era, the radiation oncologists were treating an area of the body where they thought there could be cancer. So they were treating based on the probability of having disease in a specific part of the body. So after the advent of PSMA-PET, in a patient that has a biochemical recurrence after definitive treatment, we can image and with high specificity, even at low PSA levels, all of these diseases, we can evaluate the extent and the localization of this disease. So we can give the radiation oncologists a significant amount of confidence when they're doing their treatment. So even though we don't have at the moment any studies, any results of any solid evidence basically showing that what happens afterwards, after the treatment that is based on the results of the PSMA-PET is influencing overall survival or biochemical-free survival. I know that in the clinical practice, the clinicians really rely on this. These studies are on the way, they're going to come, but the changes already happened. So the clinicians are already giving it a lot of trust in this imaging modality.